Every day, somewhere in an emergency department, a doctor is prescribing a medication that, in a different version of events, might never have been needed. And I know this because I've worked in emergency medicine for nearly 10 years. And once you've seen it enough times, like the 52-year-old with crushing chest pain who was told his blood pressure was just a bit high 5 years ago, or the 47-year-old woman with her third UTI in a year because her blood sugar has been quietly climbing for a decade, you start to ask a different question. Not just, what do we prescribe, but how did we get here in the first place? I'm Dr. Alex, and I've spent the better part of a decade working in some of the busiest emergency departments in the UK. And after years of treating the downstream consequences of preventable disease, I started studying lifestyle medicine, which is the evidence-based science of what happens to the body when you actually change the inputs. Today's video sits right at the intersection of those two worlds. This isn't a video telling you to throw your medication in the bin. That would honestly be dangerous, and it would also be very, very wrong of me to do that. What this is instead is an honest, evidence-based look at 9 categories of medication where the research shows unambiguously that lifestyle change can reduce or even eliminate the need for them entirely. We're talking about actual published clinical trials, not anecdotes. And we're going to cover the actual physiology of why it works as well, because understanding the mechanism is what helps you to remember it all. Starting with blood pressure, and it's a good place to start because hypertension sits at the root of so much of what ends up in emergency medicine. ACE inhibitors, ARBs, calcium channel blockers, these are among the most commonly prescribed drugs on the planet. In England alone, over 10 million people are on at least one of these. Now, the assumption that gets quietly built into the system is that once you're on them, and that's it. And for a lot of patients, that story calcifies into a kind of medical identity. I have high blood pressure, I take my tablets, full stop. But the evidence tells a more complicated story, and a more helpful one. What's actually happening in most cases of essential hypertension, which is the common kind, not the rare secondary causes, is a pattern of metabolic dysfunction. Visceral fat, which is deep abdominal fat that wraps around your organs, drives something called insulin resistance. Now, insulin resistance raises circulating insulin levels, which in turn activates the sympathetic nervous system, your fight or flight machinery. That sympathetic tone causes arterial constriction and raises your blood pressure. At the same time, excess visceral fat impairs the endothelium, which is the thin inner lining of your blood vessels, reducing their ability to produce nitric oxide, which is what normally keeps arteries flexible and dilated. Now, when you address that upstream dysfunction through sustained weight loss, structured aerobic exercise, significant sodium reduction by reducing ultra-processed foods, and a dietary pattern like the DASH diet, a whole food, high fibre, potassium-rich eating pattern designed specifically to lower blood pressure, all of which have level 1 evidence behind them, something really interesting happens. The sympathetic overactivation calms down, endothelial function improves, insulin sensitivity improves as well, and blood pressure falls. In real clinical practice, patients with hypertension who commit to significant and sustained lifestyle change regularly reduce or come off 1 or 2 antihypertensive agents under medical supervision. And they did all of that simply through lifestyle changes. The second category of medications is type 2 diabetes meds, and this is probably the strongest example in this entire list. And the science here is really remarkable in its clarity. So type 2 diabetes has been described for decades as a progressive, incurable condition. Patients used to be told, manage it, control your numbers, and accept that it will just worsen over time. But that framing has shifted dramatically over recent years. The DIRECT trial, which is a landmark randomized controlled trial published in The Lancet in 2018, put this to the test. People with type 2 diabetes followed a structured, low-calorie intervention aiming for significant weight loss. At 1 year, nearly half of them were in full remission, meaning their blood glucose had returned to the non-diabetic range without medication. At 2 years, around a third remained in remission. Now, these were people who had been told that they had a lifelong condition, and the physiology explains this beautifully. So when type 2 diabetes is in its early to mid stages, it's largely driven by excess fat deposited inside the liver and the pancreas, ectopic fat. Now, this fat interferes with the liver's ability to regulate glucose output, and it impairs the pancreatic beta cells that secrete insulin. Significant calorie reduction and weight loss clears that ectopic fat. Liver glucose output normalizes. Beta cell function, which had been suppressed, not destroyed, begins to recover. Insulin sensitivity improves across multiple tissues simultaneously. But there is one important nuance here. Remission does not mean cured. The underlying tendency seems to remain, and if weight is regained, then the condition typically returns. But the practical takeaway is significant. Metformin, GLP-1 agonists, SGLT2 inhibitors, these are potent drugs with real effects. And for many patients, especially those earlier in the disease trajectory, the right lifestyle intervention can make them unnecessary. That is a big deal. So number 3 is statins, and these are an interesting one, and they require a careful conversation here because they are genuinely among the most evidence-backed cardiovascular drugs that we have. For high-risk patients, those who have already had a heart attack, like my dad, or who carry a high 10-year cardiovascular risk, statins save lives. That's not up for debate, and this video is not suggesting otherwise. The more nuanced territory is primary prevention in lower risk individuals. People prescribed statins because their LDL is modestly elevated, with no other established cardiovascular disease and relatively low baseline risk. This is where lifestyle change becomes really impactful as an alternative or complementary strategy. A sustained dietary shift, specifically reducing saturated fat intake, increasing fibre, incorporating plant sterols, can reduce LDL cholesterol by a huge amount. Exercise raises HDL, which plays a role in reverse cholesterol transport. Weight reduction lowers circulating triglycerides. And crucially, lifestyle change also reduces systemic inflammation, something statins do partly as a side effect, I guess, but which is more directly addressed by removing the inflammatory inputs driving it. For a lower risk individual with no family history of premature cardiovascular disease, then an aggressive lifestyle program can sometimes shift the risk calculation enough that a statin is no longer indicated. But that decision belongs between you and your doctor, with individual risk properly evaluated. Moving on to a category of medications called PPIs, or proton pump inhibitors, with omeprazole and lansoprazole being the most familiar names. And this is a category where overprescription is genuinely a systemic problem. So PPIs are among the most widely dispensed drugs in the world, and a substantial proportion of long-term users were started on them for reasons that were always meant to be temporary. The mechanism behind most reflux in otherwise healthy adults is mechanical and behavioural. Things like excess weight, particularly around the abdomen, increases intra-abdominal pressure. That pressure pushes gastric contents upwards against the lower esophageal sphincter. Late night eating means that the stomach is still processing food and producing acid when someone lies flat. Alcohol relaxes that sphincter directly. Ultra-processed diets slow gastric emptying, and the result is that we get acid where it shouldn't be, and a prescription to suppress it. What the research shows is that weight loss in overweight individuals dramatically reduces reflux symptoms, sometimes eliminating them entirely. Elevating the head of the bed by around 20 centimeters significantly reduces nocturnal symptoms. Eliminating the specific dietary triggers, for most people this includes fatty foods, takeaways, caffeine, alcohol, and large meal volumes, produces further relief. When the mechanical cause is removed, the suppression through medication becomes unnecessary. Many patients who commit to these changes are able to step down and eventually discontinue long-term PPIs, which carries its own benefits given the associations between prolonged PPI use and altered gut microbiome and nutrient absorption. So this one is all about antidepressants, and this section requires the most careful framing of anything in this video. So I want to be quite precise. Depression is a real, serious, and sometimes life-threatening condition. Antidepressants are appropriate, sometimes life-saving for many people. Nothing in what follows is a suggestion that someone should discontinue medication without proper clinical support, or that depression is simply a consequence of poor habits. What the science does show, though, with increasingly strong evidence, is that structured exercise has an effect on mild to moderate depression that is comparable to antidepressants in randomized controlled trials. And the mechanisms are really worth understanding because they're not just vague or hand-away. Exercise honestly changes brain chemistry. It increases a protein called BDNF, which helps the brain form new connections and adapt, something that's actually impaired in depression. It dials down the body's stress response system. It improves sleep quality. It reduces levels of inflammation that are consistently elevated in people with depression. These aren't side effects of feeling better, they're the biological reasons why feeling better becomes possible. Sleep, social connection, daylight exposure, and talking therapies each add their own independent effects on top of that. They work through different pathways, obviously, which is exactly why combining them tends to produce results that medication alone often doesn't. For people with mild to moderate depression who've genuinely rebuilt these foundations, whose sleep is consistent, who are moving regularly, who feel connected and able to think clearly, coming off antidepressants under careful medical supervision is a realistic and legitimate goal that many people achieve. It's not about rejecting treatment, it's about reaching a point where the underlying conditions that drove the depression have actually changed, not just been managed. That's the distinction that matters. Lifestyle change isn't the alternative to treating depression. It's what makes recovery something that you can sustain. But obviously, I need to say, this might not work for everyone, which is why talking to your doctor matters so much. Number 6 on the list is sleep medications, and this one is particularly frustrating from a clinical perspective because we've had a better solution for chronic insomnia for years, and it's still not what most people get offered first. Sleep medications were mostly designed for short-term use. The evidence for long-term efficacy is weak. The side effect profiles are real, and yet chronic insomnia consistently leads to prescriptions for sleeping tablets that continue for years. The gold standard for chronic insomnia, established by multiple head-to-head trials, is actually a talking therapy called CBT-I, or cognitive behavioral therapy for insomnia. When directly compared to sleeping tablets, CBT-I produces better long-term outcomes. It works by targeting the thought patterns and behaviours that keep insomnia going. Irregular sleep schedules, spending too long in bed, the bedroom becoming a place that your brain associates with wakefulness, and the spiral of anxious thinking about sleep that makes everything worse. On top of that, there are the basics that directly influence your body's sleep biology. Morning bright light exposure to anchor your circadian rhythm, cutting out alcohol, which suppresses deep sleep and fragments the second half of the night despite making you feel drowsy. And the last one is keeping consistent sleep and wake times. Together, these changes alter the underlying sleep physiology rather than just sedating your nervous system every night, which is clearly never a good thing. People who genuinely engage with CBT-I frequently reduce and come off their sleep medications, and often sleep better than they did when they were taking them. Of all of the markers on this list, triglycerides are probably the one where diet makes the most dramatic and rapid difference, and that's something that most people have never been told. Triglycerides are the fats that circulate in your bloodstream, and their levels are primarily driven up by refined carbohydrates, sugar, and alcohol, rather than dietary fat itself. What happens is that the liver converts excess sugar into triglycerides through a process called de novo lipogenesis, essentially turning surplus sugar into fat and releasing it into the blood. This means that someone eating a low-fat, But high sugar diets can still have very high triglycerides. And honestly, this is something that two family members in particular that I'm thinking about struggle to get their head around. And this is a common misconception. The practical upside is that removing the drivers, cutting sugar and alcohol, can drop triglyceride levels dramatically, sometimes halving them within weeks. Adding soluble fibre, regular exercise, and meaningful weight loss compounds that effect further. Fibrates, which is the name of the class of medication that I'm talking about here, are sometimes appropriate when triglycerides are very high and cardiovascular risk is significant. But for a large proportion of people with moderately elevated levels, the dietary drivers are the actual problem. If you address those, then the medication often becomes unnecessary. Number 8 is chronic pain medication, specifically NSAIDs, so non-steroidal anti-inflammatory drugs, and opioids. Now, chronic pain is one of the most complex areas in medicine, and one where the underlying causes are far too often left untreated while the symptom gets medicated indefinitely. A substantial portion of chronic lower back pain and knee pain and hip pain is closely linked to muscle weakness, physical deconditioning, and excess body weight. The mechanisms are fairly straightforward here. Without adequate muscle support, load gets transferred onto your joints and cartilage and the connective tissue in ways that those structures weren't designed to handle. At the same time, excess visceral fat drives systemic inflammation, raising levels of inflammatory compounds in the blood that sensitize pain pathways and lower the threshold at which pain is perceived. This is why obesity is associated not just with joint pain from mechanical load, but with heightened pain perception more broadly. Structured strength training, particularly programs targeting the muscles of the back and the hips and the core, produces really measurable reductions in chronic musculoskeletal pain. Weight loss reduces the mechanical load on joints directly. Anti-inflammatory dietary patterns like Mediterranean-style eating modify the inflammatory environment that amplifies pain signaling. Physiotherapy that retrains movement patterns addresses the compensatory mechanics that often develop over time. It's a bit like if you've got a leg injury, why you often get pain in the other leg because of limping. The resultant practice is that many people on long-term pain medications can significantly reduce how much they need when these upstream drivers are properly addressed. The last category on the list is erectile dysfunction medications, and this one tends to get treated as a straightforward pharmacological fix. But it's worth understanding what erectile dysfunction is actually telling you, because the signal really matters. Erectile function depends fundamentally on healthy blood vessels and good circulation. The same process that damages the coronary arteries in the heart, driven by insulin resistance and visceral fat and high blood pressure, smoking, poor sleep, also damages the blood vessels responsible for erectile function. In fact, erectile dysfunction in middle-aged men is now recognised as an independent predictor of cardiovascular events, precisely because it reflects the same systemic vascular disease showing up earlier in small vessels. What this means in practice is that improving cardiometabolic health improves erectile function. Things like weight loss, regular aerobic exercise, better sleep, and reducing alcohol all improve the way blood vessels function and restore the body's ability to regulate blood flow. There are multiple studies that have shown significant improvements in erectile function following sustained lifestyle changes, in some cases without any medications at all. The medications work on the same biological pathway. It's all about nitric oxide, but lifestyle change works upstream of the problem rather than compensating for it after the fact. At this point, it's worth stepping back and looking at what connects all 9 of these areas, because when you see the pattern, it changes how you think about chronic disease entirely. Across high blood pressure, type 2 diabetes, high cholesterol, reflux, depression, insomnia, pain, and vascular dysfunction, the same cluster of underlying problems appears repeatedly as the driving force. Insulin resistance, chronic low-grade inflammation, visceral fat, an overactivated stress response system, blood vessel dysfunction, These 5 processes interact and reinforce each other in a cycle. Visceral fat releases inflammatory signals. Inflammation worsens insulin resistance. Insulin resistance raises stress hormone activity, and stress hormones damage blood vessels, and so on and so on. Medications are mostly designed to interrupt one specific point in that cascade. Blood pressure medications reduce arterial tension. Statins reduce cholesterol production in the liver. Metformin modulates glucose output. All of these are legitimate, evidence-based interventions, but lifestyle change, like sustained weight management, structured physical activity, dietary quality, sleep and stress regulation, these all address the cascade at the level where it originates. When you treat the source, the downstream consequences often resolve. Despite all of that though, there is something really important that I need to mention. Not everyone can reverse their need for medication through lifestyle change alone. And that isn't a failure. Long-standing type 2 diabetes, particularly where significant insulin-producing capacity has been permanently lost, may not achieve full remission regardless of how committed the intervention is. Severe high blood pressure with established organ damage, familial hypercholesterolemia, which is a condition that causes very high cholesterol from birth, and advanced cardiovascular disease all represent situations where medication isn't optional. It's necessary and potentially life-saving. Medication is a tool, one of many available in medicine, and often exactly the right tool for the job. The real problem isn't medication itself. The real problem is when the root causes go entirely unaddressed and medication becomes the only response to a disease that is still progressing underneath it. Prescribing a blood pressure tablet while leaving visceral fat, insulin resistance, and diet completely untouched doesn't solve the problem. It manages one symptom of it while the rest continues. The goal is both, right? Medication where it's indicated, and lifestyle change that addresses what drove the need for it in the first place. And it's worth saying this quite plainly because the numbers are really striking. The NHS spends in the region of £10 billion annually on prescription medications for conditions that are in significant proportion driven by lifestyle. Type 2 diabetes alone costs the NHS around £10 billion a year in total, roughly 10% of the entire NHS budget, with the majority spent managing its complications rather than preventing the disease from developing in the first place. Now, this isn't a criticism of the NHS specifically, which works under extreme pressure and amazing commitment from its staff, but it does underline what's actually at stake. Every person who achieves remission from type 2 diabetes or who comes off 2 blood pressure medications through sustained lifestyle change isn't just a better outcome for that individual. They're also reducing the burden on a system that is buckling under the weight of preventable chronic disease. Medicine needs both sides of this equation. Effective management when disease is established, and genuine, properly resourced investment in preventing it from developing at all. The way to come off medication is to change the physiology that made it necessary. When you reduce visceral fat, when you improve insulin sensitivity, when you train your cardiovascular system, when you optimize your sleep and reduce inflammatory inputs, you are not just improving numbers on a blood test. You are changing the biological environment that produced those numbers in the first place. Prescriptions often follow physiology. Change the physiology and the prescription may no longer be appropriate. Now that process takes time, it takes consistency and proper medical supervision. But the evidence for it is real, it's substantial, and it's something that the medical system as a whole has been far too slow to embrace. I really hope you got some value from this video today. If you did, then I've got loads of other videos on how lifestyle changes could help you, so please do make sure you take a look.